before we can send anything off to the ID lab, we first have to take a sample. Okay, you can't just sit there. Oh, look, they have a skin infection. Let's just rub it on some plates. Let's do this, that. They got an abscess in their mouth or endocarditis, or they may have urinary tract infection. No. The clinicians who are actually seeing the patient, touching the patient, have to somehow get a sample of the pus, a sample of the infected skin, a sample of the urine to test for urinary tract infection. However they're doing it, whatever the sample they're taking, there are certain guidelines that have to be followed. Say you're testing for urinary tract infection. Okay, depending upon which microbe you think it might be, predominantly it's E. coli, but other urinary tract infections can be gonorrhea, syphilis, or things like that if it's males. Some females can also get gonorrhea up the urethra. So depending upon what you're testing for, it's either going to be the mere presence of or how many are there that's going to be a yes or no for urinary tract infection. But the problem is that whole area down there is covered in microbes. So we have to be careful. I have to stress to the patient the idea of what's referred to as a clean catch. Okay? If the urine stream that is exiting out the urethra somehow, instead of going straight, goes off a bit, or it's a wide stream and it touches the labia, well, it's going to pick up whatever bacteria were there on the labia is now being carried off in the urine stream, which is now going to be in the collection cup, and you're going to get a false positive, presence of bacteria. Pubic hair, same thing. So nowadays they tell anyone who's going in has to pee in the cup for the testing for bacteria. Here's some wet wipes, kind of wipe the area down a bit. Does it sterilize? No. Does it disinfect a bit? Decontaminate? It cuts down on the numbers. Okay? And that's why you'll see in the doctor's restrooms or go to the labs, to pee in the cup. They'll have signs instructing you how to clean, how to wipe, how to collect. It does matter. And if you're going through and you think somebody has a throat infection, a sinus infection, or you're going to go and there's an abscess and you want to take a swab there, swab the throat, swab the sinuses. Well, to get to the throat, to get to the sinuses, and if you're going to get the abscess, around the abscess, the mouth, the sinuses are covered in microbes. So you have to be careful as the clinician, whether you're going to be the doctor, the nurse practitioner, the PA, whatever, who's taking the sample. That's why, you'll see they do the tongue depressor if they're going to go through and, take a swab of your throat. So that way they're minimizing the chance of the swab touching your tongue, touching the sides of your throat until they get to the back there and can swab there. When they're going up the sinuses, they're being careful because, the sinus pathway up through the nares, the nose, is covered in microbes. So if they touch the tongue, they touch the mouth, they touch the sinuses, the nares as they're going up to, swab the sinuses, they're going to coat the Q-tip, the swab, in microbes. So by the time they get the swab to where they need it to go, it's already covered in bacteria, and it can have a minimal chance of collecting more. So you've got to be careful of contamination. Same thing if they're doing needle aspirations. That's why they'll, yes, we're going to aspirate here because you have a boil. some sort of infection under the skin, we're going to take a needle in there and aspirate out some of the fluid so we can send it off for testing. Well, the thing is, just by putting the needle through, they are picking up microbes on the needle. They're now introducing microbes that were on the surface of the skin into the area of the infection, maybe making the infection worse. Or when they pull the plunger back, they're picking up the bacteria they just introduced from the skin, which is going to contaminate. So they have to be careful. And as you see here, they really don't leave much to chance in the medical community, okay? It's when, you see doctors who are just doing whatever they think they want to do and not paying attention or, not following set guidelines, that patients can get injured. So to minimize risk, to minimize, chances of missing something or misdiagnosing, hospitals, clinics, pretty much the AMA, all of the medical communities have put together procedures. See A, do B. Based on the results from what you did for B, proscribe C. Okay? Boom, boom, boom. So when if you talk to, a cardiologist, you talk to an infectious diseases resident, you talk to an ER resident, they pretty much know, see this, here's how I respond. See something else, this is the other way to respond. Okay? So that way they minimize the chance of doing the wrong thing. They minimize the chance of overlooking something because they've set procedures they follow. Now, chances are once they start, step 1, step 2, step 3 is going to have, okay, here's possible things to now do next, and each of those will have different. It's not all straight and linear, but by having the procedures that you see here, minimize the chance of doing damage or hurting the patient.